of nystagmus or dancing eyes as it is commonly called. This is basically a sign, not a disease process itself. It is a constant repetitive cycle, repetitive movements of the eye, which is basically a problem between the labyrinth of the brainstem and which results in these abnormal movements. So basically, nystagmus has got a slow phase, which is very important, and a fast corrective phase, which we are attracted to it. So slow movement systems, as you all know, is visual fixation, vestibular system, and neural integrators, pursuit systems. So these are the common terms which are used when we are dealing with the case of dancing eyes or nystagmus. Either it is pendular or a jerk nystagmus, depending upon the type of fast movements towards which side, and whether it is a horizontal, vertical, torsional, or circular. So amplitude is how far does the eye move, and frequency how rapidly it moves. So it can be infantile nystagmus or acquired nystagmus. Induced nystagmus is another variety which we can create, which we all know. So this is optokinetic nystagmus, which we can see at the extremes of gaze and when it is following the drum. And physiological nystagmus are normal variants of motor function. So this is by taking the ocular movements far too laterally and trying to fixate. So this can be an optokinetic nystagmus. It is multidirectional and it is in response to a moving object, and slow phase is ipsilateral to the vertical stimuli. So vertical vestibular ocular reflex, we all know when injecting, this is because of the semicircular canals. If it is a horizontal canal, you will get a type of nystagmus, caloric nystagmus, which we call. And if the caloric stimulus is given in both the eyes, it will be an upward nystagmus, because the vertical semicircular canals are also affected by it. So how to approach? So there is nothing to fear and nothing to get confused about the dealing with the case of nystagmus. You just have to ask age of onset, whether from when it is present, whether it is acute or it has been present for a long time, whether it is present from birth, and history, what the patient says, whether about the history of oscillopsia, and that shows that it could be an acquired nystagmus. So visual acuities are very important examination point which we should take. Sometimes poor vision, poor maculation, or macular disorders can result uh, in the onset of nystagmus. Macular disorders, albinism, all these can result in nystagmus. So, a study of the features of nystagmus in all cardinal positions of gaze will tell you which movement, during which movement or which direction of the movement the nystagmus is accentuated. And also we should observe the presence or absence of the head oscillations, head position, and we should also try to note where is the null point for this nystagmus. Null point is where there is a minimal amount of nystagmoid movements. So congenital nystagmus can be because of the sensory defects, as I already mentioned, and it can be associated with squint. Usually these things congenital are from birth, and sometimes autosomal dominant inheritance pattern can be seen in these patients. Acquired nystagmus can be sudden. Acquired nystagmus can be due to drug toxicity, which is common, particularly lithium can be common precipitating drug, which is commonly given nowadays for many psychiatric disturbances. Multiple sclerosis, a small nystagmus movements can give you an alert regarding the onset of multiple sclerosis. Same thing can be observed in certain cases of brain tumor and head injury. So drug toxicity should never be forgotten. So spontaneous nystagmus, It can be a downbeat nystagmus or an upbeat nystagmus or torsional dysrhythmia. The importance is these type of pathological nystagmus usually indicate type of where is the location of the lesion. So usually vertical nystagmus is located because of posterior in the posterior fossa lesions, medication side effects, and vitamin A deficiencies. So you can see the downbeat nystagmus. This is due to the herniation of the tonsils. Here you can see the tonsil which is herniated into the foramen magnum, and that results in the downbeat nystagmus. An upbeat nystagmus is usually lesions in the brainstem with other features of brainstem lesion will also be there. Um, so this will give you a clue about the location of the lesion. Seesaw nystagmus, again chiasmal lesions can precipitate this type of nystagmus. Torsional nystagmus, then retracted nystagmus due to dorsal brainstem syndrome, also to be can be a indication. So all these things what we talked about nystagmus is basically a slow phase movement with a corrective fast phase. Now when we come to fast phase, which is again very rare, this can be due to ocular bobbing or opsoclonus and flutter, which are all very rare but very difficult to not very difficult to diagnose, because you will always note that there is a compensatory head movement along with it. In nystagmus you don't find a compensatory head movement, but all these there will be a compensatory head movement for that. I offer my special thanks to my mentor and my teacher, Professor Vijayaraghavan. uh, Thank you so much for your listening. Thank you.